Atrial fibrillation always needs surgery, true or false?
It's false. And I don't even really like the term surgery.
I agree.
I mean, surgery implies something open and big incision. When we do a procedure for atrial fibrillation, an ablation procedure, it's a cardiac catheterization type procedure. So you got a big IV in the vein in the leg, catheters go up to the heart under x-ray guidance, and then we do all that work in the top left chamber of the heart, right? And so patients are generally put out to sleep. Takes about an hour, and then they tend to go home either same day or next day. But it's for symptom relief. And so if you're in that group of patients that has occasional AFib and you don't feel it, right, you don't need a procedure of any kind necessarily. For folks where it's really burdening them and it's impacting their quality of life, that's when we really talk about, do you need an ablation? And if you look at the data, ablation is clearly superior to these antiarrhythmic medications, which have their own
Right.
potential side effects. So, it so much so that the guidelines this year were updated, and the newest iteration of guidelines say ablation for paroxysmal AFib patients is first-line therapy.
Oh, wow. That's interesting.
Yeah.
And one of the medicines that's commonly used is amiodarone. But we say don't use it more than 6 months now. I mean, that's kind of a big thing, isn't it?
Yeah, amiodarone is a very strong antiarrhythmic medication that we do use quite regularly. Usually, at least within my office, we're using it post-ablation for a period of time, simply because after the ablation, the heart has some inflammation. We want that inflammation to heal. The heart wants to go back into that arrhythmia for upwards of a month, and so we use an antiarrhythmic medication to keep things under control, with the thought that when I see that patient for follow-up and their EKG looks beautiful, they're in normal sinus rhythm, we take that drug away. So amiodarone does have high risk of toxicity.
Oh, yeah.
Preferably, I like my patients to be on it 3 months, 6 months max. I know there's still people out there that keep their patients on amiodarone endlessly for years.
Yeah, it's not great practice.
Not
right?
great practice.
And it can not just affect the rhythm, but it can negatively affect your thyroid, your
Yes.
lungs, right? A whole host of toxic sort of end organ effects. And you really have to get those things monitored. So if you are staying on long-term amiodarone, there are recommendations for annual sort of lung function tests, chest x-rays, thyroid studies. It's a whole host of things that have to be monitored.
To that point, though, there are other antiarrhythmic drugs that we can utilize that are not as strong or risk of toxicity as amiodarone. So if we have patients who come who we tell them about ablation and they're, that's not the route I want to take, there are other options that we can manage their symptoms.